we're going to be doing the sternum. So Julie, I'm going to have you come over here and you're going to put your chest against the board for now. Go ahead and put my shield. Oops, sorry. I'm going to make sure that I have a 10 by 12 lengthwise cassette. Okay, I'm going to align and detent to 40 inches.
This is the one where the book recommends 30,
Oh.
but I mean, I've never worked in a department where it let you shoot
Never.
because they're worried about skin entrance dose.
Yeah.
I talk about it, but we haven't demonstrated at 40.
So I'm just going to collimate to my cassette. I'm going to start at 10 by 12 and then I'm going to collimate lower or smaller once I get there. So now I'm going to have you turn slightly towards me. Good. I'm going to use a right marker on her right side. I'm going to be looking for the level of T7, which is inferior border of the scapula. So that's the level at which I'm going to center inferior to superior. And then I'm going to look for MSP, and it's going to be 1 inch lateral to MSP. So I'm going to have you move towards me just a little bit, right about there. I'm going to collimate in to the size of the sternum. I'm not going to collimate too much up and down because I can see that her sternum starts at jugular notch, and it's right about here. So I don't want to collimate up and down too much because I don't want to miss the manubrium or the xiphoid at the bottom. Okay, I have my shielding. For this one, you're going to use a breathing technique. So you're going to be setting a very long exposure time, anywhere from 1 to 3 seconds, depending on your department. We are trying to blur out all of the structures around the sternum so that the sternum shows up nice and clear. So we blur out the heart and the ribs by continuing to breathe during the exposure. All right, so Julie, I'm going to have you just keep breathing normally and expose. Okay. Now we're going to be moving on to the lateral. So I'm going to have you turn and face away from me. I'm going to switch out my marker from my left marker. So now what I'm going to have you do is you're going to put your arms behind you, interlock your hands if you can, good, and kind of puff out your chest a bit. Good. Again, I have my 10 by 12 lengthwise loaded in the bucky. I'm going to have you take a step back for me. I am going to be centering mid-sternum, which is at the level of T7, same as before. So you can go 4 inches down from the jugular notch, since we're now on the AP side. I'm also going to angle my tube just a little bit to match the shape of the sternum. So you can see the shape of the sternum, and remember, you gotta have to visually and mentally delete breast tissue from it. But the sternum is gonna go basically like this a little bit. So I angle my tube to match that just so I can collimate in a little bit tighter. I wanna make sure I have light to the jugular notch, and then I'm gonna have you point to the bottom of your breastbone for me. And that's where I want to make sure I also have the bottom of the light field too. So you do want to collimate really tightly on this one, but not so tightly that you clip anything. This is her left side against the board, so I'm going to have the left marker. All right, and for this one, I'm going to have you take a deep breath in and hold your breath. Expose. Breathe. I like to have my patient take a deep breath in, and I watch how their chest changes as they take a deep breath. before you expose. If they take a deep breath and they really kind of lean back into it, then you're gonna have to change your centering or possibly your collimation. So I usually like to have them do like a little practice breath before I actually expose. I'm going to do ribs. Typically, as a hospital protocol, you would always start with your regular PA chest at 72 inches. Because you've already learned that, we're gonna skip that and go straight to the rib series. So we're gonna do unilateral, and for today, we're gonna do the right side. So I'm gonna go ahead and put my right marker on the board so I don't forget it. For the upper ribs, we do a 14 by 17 lengthwise. If you have a fairly short patient, their ribs might fit, their entire rib cage might fit on a 14 by 17, but we typically still do the lower ribs as a separate shot, even if they show on the upper, because the technical factors are different for the abdomen than it is for the chest. Okay, so I'm already detented and 40-inch SID. I'm going to make sure that I'm collimated to my 14 by 17. Okay. I have my shielding here. So I'm going to be looking for looking for the level of T7, so I can feel for the scapular border. I can go 4 inches below the jugular notch to get there. And then I'm going to be centering just to the unilateral rib, so halfway between the jugular notch and the lateral border of the rib cage. So I'm going to have you move just slightly to your left, right about there. So at the level of T7, you're going to make sure that there's a little bit of light above the shoulder. And then you're going to collimate to the skin border. So I can collimate in a little bit. I want to make sure I still have to the jugular notch because I have to make sure that I have all the rib articulations with the spine. So you need to make sure that you have enough on either side. Make sure that I'm aligned now that I fixed it. Move just a little bit that way. Good. We're going to bring the arm out so the arm tissue doesn't overlie any of the chest. And for this one, you're going to take a deep breath in and hold it and expose. Go ahead and breathe. Go and relax that arm for a second. For the next one, I'm going to do the lower ribs. And the lower ribs, the upper should get from the 1st through the 10th rib. So the lower ribs, we're really only trying to get 8 through 12. You need to have a little bit of overlap. So we take pictures of 8 and 9 basically in both of them. So because we're doing such a smaller area, we're going to change out to a 10 by 12 and we're going to do it crosswise. I'm going to move my marker down. And what I'm going to do is I'm going to feel for Julie's hip. And again, it's kind of more ticklish when you do one side versus two. So here's the top of her hip. I'm going to put the top of my cassette, or the bottom of my cassette, at the level of Julie's iliac crest. That's going to put us centered right about the 10th rib. And now that my bucky is aligned to Julie, now I'm just going to make sure that my tube is aligned. I'm going to change to my 10 by 12 field size. Make sure my marker's in it. I'll have you take your arm out. And for this one, you're going to take a deep breath in, blow it all the way out, and hold it out. Expose. You can go ahead and relax. Now we're going to do AP obliques. And because the right side is the side affected, we're going to put it closest to the film for the AP oblique. I'm going to go back to the level of T7. So I'm going to have you turn about a 45-degree angle towards me. Good. And then you're going to put this arm up like this. Very good. Now I'm going to have you take a step backwards. So I'm looking for the level of T7. Here's the inferior scapular border. Then I'm going to be looking to center halfway between the jugular notch and the lateral border. We want to make sure that we still have all of the medial articulations of the ribs with the spine and make sure that we're not clipping anything on the outside here. I'm going to make sure that I have my right marker up top. Maybe scoot back just a little bit. So I want to make sure that we're centered to the body part and not to the entire chest. And then make sure we only collimate to the area of interest. All right, again, take a big deep breath in, hold it, and expose. Now I'm going to show you the PA oblique. So when you do the PA oblique ribs, you're going to put the affected side away from the image receptor. You'll see that the affected side's arm is still up, but now it's not close to the IR, it's farther away. So I'm going to move on the other side for this one so I can see better. Again, at a 45-degree angle, I'm going to be looking for the midpoint between the spine and the lateral border, and that's going to be my centering point. Inferior border of the scapula is still at T7, so I shouldn't have to change anything there. And I'm just going to make sure that I have my marker on the correct side. Right side. All right, take a deep breath in and hold it. Expose. You can relax.
And just to add, the only time you would need to do oblique lower ribs is if they didn't show up on the AP. If someone had a very large abdomen and ribs 8 through 12 were not well penetrated, then you'd have to do separate lower obliques. But for the most part, you can usually get away with just the AP oblique upper or the PA oblique upper. Your clinic site will probably call this series an acute abdominal series. And the order may just read out AAS. The acute abdominal series includes a PA chest x-ray, an upright abdomen, or a left lateral decubitus abdomen, and then a supine abdomen. So it's a total of 3 views: chest, upright or decube, and supine. So I would have already done her PA chest x-ray, and then I would probably move right into my upright abdomen. It's going to be done at 40 inches. That looks like it's detented already. I already have a 14 by 17 lengthwise in the bucky. I'm going to go ahead and I'm just going to add my right marker right now. Probably put it down low. Okay. And then as I'm walking the patient into the room, I'm kind of gauging how tall they are compared to me. And then as I'm positioning the bucky, I'm going to put this roughly where my crest is, so that the adjustment that I make with my patient is very minimal, and I'm not moving it several inches. I may be moving it an inch or 2. So I'm collimated to 14 by 17, lengthwise, showing slight collimation on all 4 edges. Centered. Okay, I'm going to have you stand with your back against the board. Okay. I'm going to feel for the top of her iliac crest. And this time, my central ray is going to enter 2 inches above the level of the crest, because I absolutely have to include the diaphragm on this. So where I'm at now, I'm about 1 inch above. I'm going to go 2 inches above. Now you can also see I'm relatively at the level of her armpit. The clinical site is going to show you put the upper border at the armpit. The book and what's on your test is going to be 2 inches superior to the crest. So the armpit works, but you have to memorize crest. All right, so I'm centered. I'm also going to be mid-sagittal plane. If I can collimate in a little bit more, I will, but I also want to make sure that I'm not collimating off my marker. And so I'm going to leave her open to 14 by 17. By centering 2 inches above the crest, I'm including her diaphragm. We're looking for free air on this. And if you clip the diaphragm, you may very likely clip any free air, because it's going to rise to the top and get trapped under the diaphragm dome. And if we clip the diaphragm, we might not see that. So this is my AP upright abdomen. If you can shield, it's per department protocol, and it's going to be below the field of view. So I'm definitely not going to be shielding her ovaries, but on a male I could definitely shield. It would just be below and out of the field of view. All abdomens are done on exhalation, so my breathing instructions would be: take in a breath, blow it all the way out, blow it all the way out, hold it out, don't breathe, expose. You can breathe. Okay, then I would move into I've done my PA chest, my upright abdomen, and now I'm going to do my supine abdomen. Head here on the pillow. Go. Again, it's going to be shielding per department protocol, which more than likely means no shielding. However, if this was a male patient, you could put the corner of the shield like this. So, I'm not going to shield for this one. 40-inch SID. And a 14 by 17 lengthwise IR. My right marker, and I usually put the marker in the place where I think it will least likely interfere. This is most likely going to show up right in the wing of one of the pelvic bones, and will not interfere with any of the anatomy of interest. So I'm centering my bucky. I've already detented my tube. So we're set to go, and at this point, then I would just use the foot pedal to make any other adjustments. So this time, once again, feeling for the top of her crest, I'm centering at the crest this time. I do not need to include diaphragm on this. What I'm including at this point is the lower half of the abdomen to the symphysis pubis. So I'm centered mid-sagittal plane, level of the iliac crest, shielding per department protocol. I'm going to double check to make sure that she is down the center of the table, and that looks good. My breathing instructions would be: take a breath in, blow it all the way out, stop breathing, expose. You can breathe. Okay, so most techs like to do upright abdomens. In the event that you have a non-ambulatory patient, or the physician has particularly requested a decubitus abdomen, unlike a chest decube, abdomens are always left side down. A chest is whatever side the effusion is in, but an abdomen is always left side down. And just like for the chest decube, the patient needs to be in that position for at least 5 minutes. So typically what I do is I move the tube out of the way, I get the patient on the table laying on their left side, and then I set everything else up. Normally it's the other way around. You want to be set up as soon as possible so that the patient doesn't have to hold the position for any length of time. On decubitus x-rays, that's the first thing you do, is put the patient on the side that they need to be laying on, and then by the time you get your gridded cassette, you get your tube set up, everything is ready to go, they've probably been on the table for about 5 minutes. And so that's what we're going to do. now, because I prefer to do AP, and I need her on her left side, that means that I need to have her head at the other end of the table. So, what I'd like you to do is just go ahead and sit up for me and bring your legs off the side of the bed, scoot a little bit this way. Okay, now I'm going to have you lay down with your head at the other end so that your left side is on the table. Okay. So, you can move on up here. Go, just bring your arms up like that, that's good. So we're using our cassette holder again. I have a gridded 14 by 17 IR. This is, the lower edge is below the decubitus sponge, but you want to make sure that your patient is centered to the IR. So in the instance where you have a thinner patient, I might build her up a little bit, but the important thing is that you see both sides in the image. The chest is more important because you're looking at side down for the condition. On an abdomen decube, we're looking at the side up. So even if the side down is not clearly penetrated, or even if it's a little bit clipped off, it's not critical because we're looking at side up. So I'm going to center this roughly, again, 2 inches above the level of our iliac crest because I want to include diaphragm on this, a little bit high. And then I'm going to have you slide your shoulders and hips all the way back until they touch this board. Okay, very good. Double check my centering. Here's crest. I want the center of my IR to be about 2 inches above that. That looks pretty good. I'm going to mark the side that's up. I'm going to turn this horizontal here. This particular IR holder has a right and left display. I can actually use this. And then I would also place an arrow, or when you're annotating afterwards, you can type in upright or type in decube so that the physician looking at the image knows that this is her right side, and the arrow indicates that it was done in a horizontal position. So I'm going to take my tube all the way out. And I'm going to use green, and then I'm going to use purple. I roughly want this to be at 40 inches. So I know that I'm centered to her body because I want it to be 2 inches above crest. So now I'm just centering to her mid-sagittal plane, and I can collimate down because she's a thinner patient, and make sure I have no light on the wall in either direction. And because now the marker that's on the stand doesn't show, I am going to have to put my right marker in the field of view. The sticky's gone. Okay, so pretend it's there. Okay, no shielding per department protocol. You could shield a male, and your breathing instructions now after 5 minutes would be take a breath in, blow it all the way out, hold it out, stop breathing, expose. All right, so that is our left lateral decube in AP projection.